All right. Hi, everybody. I think we're going to get started. My name is Avery. I'm a first-year doctoral student in the MAPP lab, and I'm going to introduce our speaker today. Today we have with us Dr. Jaime Perales Puchalt. He's an assistant professor at the University of Kansas Alzheimer's Disease Research Center. His background is in psychology and public health. In addition to conducting research in Spain, England, and the US, Dr. Perales has collaborated with teams from other countries in the European Union and the Americas. He has a primary focus on reducing Latino dementia disparities with his research, has led to the development of a dementia education and recruitment tool for Latinos. He's also studied the risk of dementia and mild cognitive impairment among sexual and ethno-racial minorities, and he currently leads federally funded grants to understand and reduce disparities in dementia care among Latinos. One of those grants includes the first text message caregiver support program for Latino family caregivers, Cuida Text. Dr. Perales holds a PhD in biomedicine and public health and an MPH in public health from the University of Pompeu Fabra, Barcelona. He also has a Master of Science in Psychology from the University of Valencia, and he joined KU ADRC in 2017 after a postdoctoral position at Juntos, Center for Advocating Latino Health at KU Medical Center. Thank you so much for joining us. And just for everybody listening in, if you have any questions, feel free to put them in the Q&A and we will address them at the end. So I'll pass it over.
Thank you so much for your kind introduction, and thank you everyone for having me here. So you've already summarized my presentation. I'll still give it. So my presentation is entitled Eliminating Dementia Disparities Among Latinos via Research. And what I'm basically going to do is I'm going to obviously give a little background at the beginning, but summarize the research that I've done ever since I arrived in the United States and worked in the dementia field here in this country. Can you all see this screen? I believe yes, right?
Yeah, we can.
So, thank you. Here's the outline. We're gonna, and this part you will probably, most of you will know at Dr. Quiroz's lab, but who are Hispanics and Latinos? What determinants of health do they experience? What are their disparities in dementia? A brief introduction to our team, and then the work that we've been conducting here in the United States in dementia disparities among Latinos. So let's start with who are Hispanics or Latinos, and the census defines Hispanic and Latino as a person of Cuban, Mexican, Puerto Rican, South or Central American, or other Spanish culture or origin, regardless of race. In order to identify as such, you have to self-identify. The same with race, by the way. So someone who's Latino can identify as white, Black, Asian, or any other race, or the combination of all of them, or none, whatever they decide to identify with. There are different terms being used. I usually go with Latino, but some people use Hispanic, Latinx, Latine, etc. I welcome them all, and I hope everyone does, as long as they're respectful. But they all have their own specificities that I believe your lab has already discussed in 2020 or 2021. I believe it was a very interesting discussion. On the right, I'm showing a map of the United States and the most frequent Latino subgroup by county. And as you can see, Mexicans and Mexican Americans are basically the most frequent group, but then in Colorado and New Mexico, we have New Mexicans or Spanish. More in the east side, we have more people of Puerto Rican origin. And then around the Miami area, South Florida, we have more people of Cuban origin. And then there's other groups in other places, but the Latinos and Hispanics are not a monolith. They're a widely diverse group, not just with regards to their origin, but also citizenship status, socioeconomic status, educational level, which can reach, from 0 to as many years as it takes. So very, very diverse group. Hard to put everyone into one basket, really. This is just a graphic, a simple way to show some of that diversity in the Latino and Hispanic group. Physical traits, professions, among other things. Latinos comprise approximately 16-17% of the U.S. population right now. They are projected to increase up to 30% by 2050, almost catching up with the non-Latino white group. Latinos also have one of the highest life expectancies in the United States. It's second highest, only after non-Latino Asian Americans. And the projections say that the 65 population going to increase more among Latinos than any other group, as you can see here. Obviously with aging, there's a higher risk of dementia, among other things. Latinos, believe it or not, when I tell people about Kansas, they think, oh, are there Latinos there? But yes, there are. It's not just Florida, Texas, California, where we are located in KU, Wyandotte County. Approximately 1/3 of the population identifies as Latino. And then when we look at Southwest Kansas, they reach up to 60.8% in Seward County, almost 50% in Finney County, etc. That is traditionally Latinos, especially people from Mexico, will arrive via the Santa Fe Rail, and this is where with the highest numbers of percentage of Latinos are, because they tended to have factories, meatpacking factories, or agricultural industry in those places. In fact, here in Wyandotte, the enclaves of Latinos are right by the railway, which is really interesting. Now I'm going to talk about determinants of health disparities among Latinos. And so the one on the left shows that among adults ages 18 to 64, Latinos are more likely to be uninsured compared to non-Latino whites. Many of these things will also apply usually, unfortunately, also to non-Latino Black individuals. The right one shows the percentage of adults who have earned an associate degree. And as you can see, Latinos, Hispanics, they say here, have a lower access to education. This one represents or shows the median household income by race and ethnicity. And as you can see, Latinos are the second lowest, have the second lowest household income, below mean for all races. This one's a little more packed, but I'm going to go little by little. Latinos also have more deportation fear, or particular deportation fear. And this one is from the health retirement study. And what it shows is the deportation fear on behalf of yourself or someone you know, like a friend or a family member. And you can see that even those who were US born citizens, 35% of them have deportation fears, which increased actually from 2016 to 2018. Obviously, when you look at those who are likely undocumented, that is through the roof. It's like 80% or so, which decreased for a while, but also increased starting in 2016. Latinos also report, this for the Pew research, also report being called offensive names, being told to go back to their country, criticism for speaking Spanish, unfair treatment in general. And Latinos also experience language barriers, obviously mostly those who are foreign born, but also some percentage of those who are US born as well. There are some shared cultural elements among Hispanics, such as familismo, collectivistic orientation, personalismo, and the importance of warm interactions, machismo, strong sense of role stereotypically masculine, and fatalismo, subjugating events to destiny. Now, this is not everyone is like that. Obviously, we can't generalize, and this is a continuum, and Latinos might be higher in some of these compared to non-Latino whites. But obviously, we shouldn't generalize. These can be negative for some health outcomes and positive for some others. Now I'm going to talk about disparities among Latinos, disparities in dementia specifically. I categorize them into 4 different types. So disparities in the risk of dementia and risk factors, disparities in receiving detection and care, disparities in research participation, disparities in dementia knowledge. We're starting with disparities in risk. Even though this is from Latinos Against Alzheimer's, I believe this statistic came from the Alzheimer's Association at some point, and Latinos are 1.5 times more likely to get Alzheimer's and other dementias compared to non-Latino whites. This one is from Latinos Against Alzheimer's, I believe, from a report. And the number of U.S. Latinos living with Alzheimer's disease is predicted to grow by 832% by 2060. So there's a tsunami of Latinos with dementia coming our way. We need to be prepared to reduce their risk, to hopefully one day cure, and also improve their quality of life and their families. Now I'm going to show some research that has compared different ethnic racial groups, including Latinos, and with respect to the risk of dementia. This one is from the New York, a study conducted in New York. It might be the YCAP or an older version of the YCAP. Northern Manhattan, the Manhattan study, the Manhattan. And what it shows is that Latinos, irrespective of the age range, they have a higher risk compared to non-Latino whites, higher risk of dementia measured as the prevalence of dementia. As I mentioned earlier, non-Latino Black individuals are usually pretty similar too in that respect. This one, interestingly, was got a sample from Kaiser Permanente in California. Kaiser Permanente is a healthcare insurance company, and what it showed, and followed them for many years, what it showed is that Latinos didn't have a higher risk of dementia longitudinally, so incidence compared to non-Latino whites, whereas other groups such as African Americans, Native Americans did. Some studies have speculated that it might be could be because of the region, could be because of in the California group there's more Mexican Americans, whereas in New York there are more people of Caribbean origin, etc. I'll talk about that a little more later when I talk about my studies. This is a very recent study, basically mimicking the research conducted by Mayeda, the previous one that I explained, that I talked about. But it does the same in a random sample of the VA healthcare system population. What they found here is that Latinos, or Hispanic, they call them here, are twice as likely to get dementia compared to non-Latino whites. They have, in fact, the highest risk of all the other groups. Very, very big sample, by the way. Just like the other one, huge sample sizes. This one from the Health Retirement Study, conducted by Jennifer Manley, very recent as well. We found that Latinos didn't have a higher risk prevalence of dementia. They had the same, approximately, like very similar prevalence of dementia compared to non-Latino whites, but they had a higher prevalence of NCI. This one, what they did was they compared, they tracked basically the Determinant study again, and it's looking at the prevalence at different time points and how it evolves in time. In general, the prevalence, as you can see, has gone down both in men and women. However, the gap is still there, as you can see, between Latinos, who are the ones in red, and non-Latino whites, the ones in green. The gaps are still there. In fact, among women, it's really interesting because it looks like for a while it even went up, and it's basically remains stagnant, whereas for non-Latino whites and African Americans, it's gone down. Now, regarding dementia knowledge, this one is also a national survey that found that Latinos have a lower knowledge about dementia compared to non-Latino whites as well. If you know less about dementia, you're probably going to be less likely to find help if you have it or your family has it, or to try to reduce the risk as well. Research participation. Latinos are underrepresented in Alzheimer's and dementia research. In the United States, in the 65-year-old population in the United States, Latinos comprise 9% of the population. However, they comprise only 4% of NIA dementia trials. Now, this was a while ago, 2007. I believe they're still underrepresented, and you probably know that they still are. And then 0.4% they represent of private randomized controlled trials for dementia. Latinos also represent a 12% of the 50-year-old population in the US, but only when I looked, this was 2018, represented 8% of the NAC 50 plus population. So they're both in clinical trials and observational studies, they're underrepresented. The NAC, National Alzheimer's Coordinating Center, by the way, is one of the largest cohorts in the United States of people with dementia and cognitively healthy people as well. If we don't represent Latinos adequately, what we're likely doing is that the findings do not generalize to Latinos, and the findings might in fact lack internal or lose internal validity in a way as well. And we're probably advancing the science for the groups that we're representing, most likely non-Latino whites who are more affluent, and we might be widening the gap because with the ones that we're not including, because those advances might not apply to Latinos and other groups that are not so represented. So disparities in detection and care. Latinos remain underdiagnosed and untreated. Here we have on the left that among people with cognitive impairment, 46% of non-Latino white individuals said that they've been told by their doctor that they have cognitive impairment. This percentage is lower among Latinos. Then also with regards to percentage of patients with Alzheimer's disease who've been treated with anticholinesterase inhibitors is also lower among Latinos. The percentage of use of Alzheimer's caregiver support access is also lower among Latinos. To the left, we have these are two different studies, but that used very similar methodology, epidemiological study that used very similar methodology. And what they found is that Latinos had a higher prevalence of basically each and every behavioral symptom of dementia that you can see: depression, irritability, anxiety, disinhibition, etc., compared to non-Latino whites. Whites comparing is data from the SALSA study with the Cache County study. On the right, if you look at the straight lines only, the blue one is non-Latino white, the right one is Hispanic. So you can see that levels up, like percentage of people of caregivers, the dementia caregivers with depression is higher among Latinos 2 years before their loved one is diagnosed, when their loved one is diagnosed, which is what the 0 represents, and 2 years after the loved one was diagnosed. So they're basically Latino caregivers are more depressed than non-Latino whites. So just to talk a little about my team, we're the Latino Brain Health Lab at the KU Alzheimer's Disease Research Center. We have a new partnership called Juntos for Brain Health. It is our alliance with another group in my same university that does research specifically with the Latino population on any topics. And so we created this brand that basically merges both of us in order to eliminate dementia disparities or brain health disparities among Latinos via research, education, and service. Here you can see Monica, who's one of our research assistants, and Leonor, who are giving a presentation in an affordable housing place. This one, interestingly, is mostly, it's a majority Latino affordable housing place, but because there were some people who didn't speak Spanish, they spoke English. They were given it in both languages at the same time, which is something that we do actually quite often. And to be broader, we develop our intervention with and for the community. So we do needs assessments, we do advisory board groups, working groups, and other, all types of mixed methods research to co-create our studies and our interventions with the Latino community, which is what this one represents. This is the community themselves. So for example, Latino caregivers, we created a text message program to support Latino caregivers. We also collaborate with, or we consider part of our team, extended team, the national and local associations such as churches or the affordable housing place that I just showed, or senior centers, etc., and also community and university healthcare institutions. Now I'm going to talk about how we have been addressing risk disparities among Latinos with our research. This is a study that we published in 2019 using data from the National Alzheimer's Coordinating Center with a sample of almost 10,000 individuals. Among them, a little more than 2,000 identify as an ethno-racially minoritized group, and what we found what we did with this is we wanted to see if the risk of Latinos varies by subgroup, right? If they're Caribbean or they're Mexican Latinos, etc., which was informed back then by the Mayeda study that I explained some time ago, and the one in New York and the one in Mexico and California. What we found is that Mexican Latinos didn't have a higher subhazard ratio, so a higher risk compared to non-Latino whites. But Caribbean Latinos and Central South American Latinos did. This is actually aligned with those findings, and in fact, the same year, the Sol Inca study by Hector Gonzalez found a very similar finding, that Mexican Latinos didn't have had a lower risk compared to, I believe it was Puerto Rican Latinos specifically. So that was really interesting to find. Now, a big caveat of this study, the NAC study in general, it's not representative. And so non-Latino white individuals are more likely to be recruited from memory clinics, whereas Latinos and other minoritized groups are more likely to be recruited from the community, which if you're recruited from a memory clinic, it's more likely that you're there because you have a problem. So we might be underestimating here these risks for the minoritized groups. We also, this was led by Dr. Ashley Shaw, who's also at the Outreach and Recruitment Corps, where I am at the ADRC. And we summarized the prevention trials. We wanted to do a scoping review of non-pharmaceutical interventions on cognitive function among Black and Latino older adults. I personally study Latinos, and she works with the Black community. Specifically, she's interested in nutrition clinical trials. So if anyone of you is interested in that, please make sure to contact her, Dr. Ashley Shaw at KU. So among we found 8 studies. 4 of them were one-arm trials, and the other 4 that are included here were randomized trials. And out of those, these randomized trials, there were 2 only with Latinos back then. One was by Dr. Marquez, and this is, if anyone knows him, he's got a very cool study or intervention that's about Latin dancing, so salsa, cha-cha-cha, etc. as a way to do exercise and stay cognitively and socially active as well. And they compared that to a health education group and found that the intervention group had more improvements or a better episodic memory. Whereas the other study was by Piedra et al., which and it was the very similar name, Caminemos. So one is dancing and this one is walking. Now they had two groups, and the control group was really very similar to the other group. They both had walking as the exercise, but what changed was that the intervention group had age reattribution, which is basically having them understand that you can exercise at any age. Age is not something that should impede you from exercising. And the other one just had general health education. They didn't find differences between those two groups, but they found that in both, let me see, but there were improvements in a modified version of the mini mental state exam after 1 and 2 years. Now I'm going to talk about the research that we've done with regards to dementia knowledge in the Latino population. And when Avery was introducing me before, she talked about a educational tool. This is the educational tool. It's a 45-minute basically presentation created for the Latino community, an Alzheimer's 101, but there's a lot of interaction. We created the I call it intervention, but the presentation together with the Latino community in many different iterations with experts in Latino health, with promotores de salud or community health workers, and with the community themselves. And it's very visual with simple language. We took into account basically many different things that the Latino community said it would make it easier for people to learn about Alzheimer's and other dementias. And so we use this one-arm paradigm in which we do a lunch and learn session at a community venue. We give them a survey at the beginning asking for knowledge. I'll explain the outcomes later. We do the 45-minute session, and then we give a survey right after, right? And the idea is to compare, pre and post. We did this with 3 different samples. Like the first one was with Latino serving professionals, and this would be people working in community centers that serve Latinos, for example. Themselves, the large majority were Latinos too. Then with Latino adults in community centers, so they could be, as long as they're over the age, 18 or older, they were included. And then a third one was with Latino seniors in senior centers. These ones are people 60 years old and over. Let me go ahead and close my Outlook. All right. Okay. On the left, we have basically the knowledge questionnaire or objective knowledge questionnaire. It's a validated tool called the epidemiology, etiology, disease scale. It was already validated among the Latino community before in the United States. And what it is a 14-item true and false questionnaire with things such as dementia is Alzheimer's is a normal part of aging. Alzheimer's has no cure, and you will say, true or false to all those. In the end, you get a score from 0 to 14. Each question you got right is 1 point, basically. As you can see in the 3 different samples, Latino serving professionals, we had 40 people, Latino seniors at senior centers, 50 people, Latino adults in community centers, 37. All the levels of knowledge all got to increase by approximately 2 points. All those are statistically significant, by the way. Cool thing is we got to also see that their self-perceived knowledge also increased. These were one items, like a one item asking something like, do you feel like, how much do you feel you know about dementia, from very low, very high, and also increased in a similar fashion among all 3 groups, also statistically significant. With regards to research participation, in one of those 3 samples that I mentioned, we also asked in the questionnaire their level of interest in participating in dementia research. So again, we within the same, the same study, right? Lunch or Learn, pre and post questionnaire. We also collected some metrics that I'll explain very soon. But what we found is that their level of interest in participating in dementia research also went up from 2.8 to 3.2 in a 1 to 4 scale. 1 is not at all. 4 is very interested. And also, we also tracked their enrollment, the enrollment of those basically initially 50 people, 50 seniors into the National Alzheimer's Coordinating Center cohort from November 2017 to August 2018. So let me walk you through this. We initially gave, I think it was 6 different talks at this in 3 different senior centers, and overall we reached 50 Latino older adults, Latinos 60 and older. Out of those, 32 of them, they gave us a contact slip that we asked for almost by the end of the presentation. We gave a contact slip and said, hey, if you're interested in participating in our cohort study, where you can also, besides participating in research, you can also get, it's a way to get a screened, right, for your memory. Please write down your contact information and we'll call you to participate in this study. So that will be 32 people out of those 50. These people, additionally, they told 6 other people that did not come, what we call a snowball. Basically, so overall, from those 55 in total, we end up having 38. Out of these 38, 32 screened positive into the cohort study, and out of those, and out of the total 55 that we talked about, we ended up with 23 participants, 41.1%. So 41 out of the people that you talk is a good percentage, honestly. That obviously depends. This was a simple, this was a simple study, like a observational study. There was no intervention and the burden is very low. We didn't collect biomarkers, for example. It was all like questionnaire based and testing, like cognitive testing. The only biomarker kind of biomarker that we took was height, weight, waist circumference, that sort of thing. Yeah, I believe it would have been lower had we added some other MRI or something like that. We also summarized the representation of Latinos and other people of other races and ethnicities in prevention or risk reduction trials. So Dr. Ashley Shaw again conducted a systematic review of the representation of different minoritized populations. We ended up finding that 42 studies that were about prevention trials, basically in the United States. Out of those, 62% only reported race ethnicity. So that means that almost half of those studies did not report race ethnicity, which makes me suspect that their diversity was not huge. Also, out of those 62 that did report, 9.6% of their samples identified as Latino. So 9.6 is not bad, but if it were of the 100% of all the studies, but not of the 50% of all the studies, right? So for me, a conclusion here is that they're still underrepresented in this type of trials too. Regarding detection and care, we have this same idea of education trials, the pre-post. We have applied it also to healthcare professionals, specifically to primary care providers and health navigators. And we use the same thing, gave them a survey at the beginning. And this was instead of 1 out, like 45 minute session. This one's a 6-hour session, talking about how tools you can use to screen for dementia, the different types of dementia, how to provide care, treatment, etc. There's a section that I gave myself that's Latinos and dementia. The other ones are other 3 professionals here at the ADRC. Let me see. So we did among 22 primary care providers. We saw this because we're talking about Latinos now specifically, that their perceived ability to serve English-speaking Latinos went up from 3 to 3.4 in a 1 to 5 Likert scale. The perceived ability to serve Spanish-speaking Latinos went up even a little higher, all statistically significant as well, from 2.1 to 2.8. And we found a very similar thing among health navigators. These are mostly social workers, but also other similar professions. You can see how it also went up more so for serving Spanish-speaking Latinos, which is good because they started with a very low score, their perceived ability. So that's a good sign that's increasing more than the English-speaking Latino group. Apart from that, we also measured other outcomes that are more generic, such as their confidence in what they know about Alzheimer's, their attitudes towards caring, providing care to people with Alzheimer's, and their care disengagement, or how much they prefer, for example, to serve people with other conditions rather than dementia because they're not comfortable, which is the only one that went down, and which is a good thing that it goes down. This is my latest study that I've completed. It's called Cuida Text. Is the first text message caregiver support interventions for Latino caregivers, family caregivers of people with dementia. And the idea here being that Latinos have, as I showed you guys before, Latinos have a lower access to dementia care and dementia care support, caregiver support, but they are the highest users of texting technology. So cell phones and texting specifically. Not so much, for example, having computer ownership is very low. For example, using video calls is relatively, not so much, but relatively lower. And the highest usage that they have is for text messaging. And basically, almost all adults have a cell phone, and most can text and write. And the age gap for texting is lower than, for example, the gap for using Zoom or something like that. That can be more complicated, and they can be internet issues and loads of different barriers, honestly. So there's a study that year one we developed the intervention informed by other interventions that have shown to work, like Reach Caregiver, for example, the Fotonovelas for Latinos, and the Savvy Caregiver, etc. We got ideas of what worked, and turned these ideas into text messages, basically, and we worked with the Latino community to adapt those messages to their reality, right? So they suggested new messages, and the ones that we created, they edited them as well to make them resonate with their reality too. And we ended up with a library of about 2,000 messages, but we only send people about 300, and then they can choose to get more. I'm going to explain that now. It's a 6-month intervention. It's bilingual. As I mentioned, it's created with Latino community. And so people will get approximately 1 message per day. Everyone will get the same 1 message per day. Those are what we call core domains, core messages from each domain. Domains being ones down here: education, caregiver support, caregiver care. So that way, for example, stress coping techniques. Support, which can be how to get support from your family, from your doctor, but it could be also resources in the community. We'd also talk about grief, problem-solving strategies. And these are specific tips for example, how to make activities fun for the person with dementia, but also safe. There's another one, for example, on how home would be how to keep the home safe for your loved one. Then behaviors, these are all behavioral symptoms and tips on how to address them. So everybody receives one message per day on all these topics that we consider core, but because every person has different needs and all families have different needs, they also have the option to interact with the program and send any of these keywords. As they can send it as many times as they like. Have approximately 50 messages from each of these, maybe some of them a little more, some of them a little less, a little fewer, that can help them with specifically. If you want more messages on how to cope with stress, you can send the word stress. Every time you do so, automatically you will get a message on how to cope with stress. And then there's a second way to interact besides the keywords, and it's the live chat text messages. So every time they send a message that like you would send a friend, just a normal message, there's a person on the other side. It's basically my research assistants right now, who are basically serve as coaches, and they can help you. You can reciprocate and say thank you, but you can also ask things for example, can you help me find a geriatrician in my region so that we can take my loved one there, and that person will help them during business hours. The keywords, the good thing is they will receive the help immediately, whatever you are at any time. The live chat messages, it's during working hours because it's a person who will be responding to those. So yes, the best thing about this is you don't have to be at a specific time at a specific place to receive the intervention. You could read it whenever you like. It's not burdening, etc. So we did a pre-post assessment, just like the other ones, in a pilot study with 24 Latino caregivers. I'm showing here the efficacy outcomes, but first, because this is a feasibility study, let me talk a little about the feasibility. We enrolled everyone in 2 months. In less than 1 month, we recruited during 2 months, which went a lot faster than I expected. Honestly, the levels of satisfaction of participants were very high with the intervention overall, and with different components in particular. Let's see. No one quit the program, but we had 2 people out of the 24 who decided, so we didn't respond to the follow-up assessment at 6 months. So we lost a couple of people there. And let me see. And in general, they perceived that the intervention helped them care for themselves, for their loved ones, learn about dementia. And these are, you can see the trends, and also most of them statistically significant change in lowering caregiver depression, burden, increasing competence, reducing strain, increasing dementia knowledge, and increasing neuropsychiatric symptoms or behavioral symptoms of dementia in their loved one as well. We also got some qualitative reports that, they said, for example, they loved that the information was given in pills of information. So the dosage they really liked, instead of giving them here's a ton of, here's a book, or here are pages. Like, no, you give them a message at a time, and it's easier to digest. And something that I really like to hear is when several of them told me that they felt supported even when they weren't texting, because they always had the chance to text us and receive a response. But even when they didn't do it, they still felt supported because they had us in their pockets, basically. Regarding current and future projects, and I'm almost finishing here. Basically, we are capitalizing on the Quitatext intervention and applying it in different contexts. Well, first of all, sorry, I forgot to say, we're continuing to train primary care providers in dementia care, but I mentioned about the texting. It's also true. We are enrolling Latino family caregivers in a caregiver support study that uses CareText plus monthly phone calls, where we can, during those calls, identify unmet needs and help families address those problems. So if you guys know anyone who might be interested, it's a nationwide study. We are recruiting even as far as Puerto Rico. So yeah, give them my contact. We've adapted this intervention to, because it didn't exist. There weren't dementia text message programs for anyone in general, not just for Latinos. So we've adapted it also to other ethnic groups in the United States, and we are implementing this intervention, the adapted intervention, with 150 Latinos in the Latinos, family caregivers of any ethnic or racial background, and 5 Missouri counties around us. And you can see some fingers crossed there, because we recently resubmitted an oral one to assess the efficacy with a fully powered sample of 288 Latinos in Kansas for Quita text. And with that, thank you so much for your time. And I think I was punctual. Good. So I'm open to any questions you may have. Thank you.
Thank you so much. If anybody has any questions, they can put them in the Q&A and I'll read them out. I had a question about the intervention over 6 months. Did you, was engagement like stable, or did people, like, was there fluctuations with participants? Yeah.
That's a very interesting question. I would say it's, I calculated it the other day. I wish I had the numbers, but, you know, for at least for a few people, when they heard, because we, after every month, we tell them, hey, great job on staying in the program. Just so you know, we got these many months left, right? And when they got it to the last month, some of those people started texting keywords like so much just to be able to get all the information, because they were very, you know, they wanted to get it all before the program ended. In general, what I think happens here is, as you saw, we have a lot of different keywords that they can use. So we don't rely on them and, you know, to remember those keywords, because there's so many. What we do is we remind them every day or every other day. You know, we send them a message and we say, and if you want to hear more messages like this, text this keyword. So you remind them every so often, so you can see a trend of them using the keywords that you remind them that they can use. Obviously, we remind them of all of them, just at different moments. And that's really the trend, except for that very end, like I mentioned, when they start like using it like a lot more.
Great, thank you so much. And
that's then, I believe they sent, if I'm not wrong, 70 messages per participant during the 6 months. You know, I think a little less than a half were the text chat that they can text anything. There's a lot of thank you, or this happened to me, or, you know, being grateful. There's a lot of that. Some of them were also asking for help, not that many, but some. And then the other half are keywords. There's a lot of keywords on, for example, learning relaxation techniques, for example. That was a big one.
Great. And there's a couple questions. I'll read the first one.
Sure.
You can speak to your efforts towards recruitment and retention plans towards the Latino participants a little bit.
Efforts towards recruitment
and retention, yeah, of Latino participants.
Well, the most important thing is I think is to build partnerships as early as possible, because that it's not easy. It's not something like, hey, here's my study and people will come to you. This takes a lot of time, and I've been building this since before I worked here, I worked at Juntos, who are actually collaborating with me now in this partnership, and I was already building a community partnership starting in 2015, and those partnerships take time and a lot of honesty, a lot of being there, even if you don't have a study right now for them. So cultivating those partnerships, I think, is the most important thing, for sure. Also, the fact that we are developing research for Latinos. So all these ideas came because I went to the community and I asked, what are your top needs? Dementia knowledge was the top need, but then affordable and accessible dementia care was another one, was one of the other needs. So I'm tapping into their needs. If you create something that they don't need, they're probably not gonna be interested in participating as much. And also the fact that we are co-developing not just what we want to do, but how the intervention is also informed by the Latino community. They tell you, for example, this one's a good one. We were asking how many messages per day should we send everyone, and initially some people said, oh, I would like 5. People who are very, very excited, and some people said, you know what, if you send me more than 1, I quit the program. So we decided in general we would just leave it at 1, with the additional, if you want more messages, you can always, interact with us to get more. But that's the way that you prevent people from quitting the program, and so that kind of talks to retention as well, and diversify also. So churches have brought, so to me, well, it depends on the type of research, right? The research that I did on knowledge, it was mostly senior centers where I got the most people. Senior centers don't have as many people who are cognitively impaired. So it doesn't mean that productive in that respect for the dementia caregiver. Dementia caregiver is more partnering with community clinics. So diversifying, having, trying to build partnerships with different sectors of the population is very important to be able to find those participants, because yes, we also get some participants from KU, but KU, I wish it represented more of the community that we have here. There are not that many Latinos in our health system. It's more, we're looking more people in the community itself, rather than, we're still getting people from the clinic, don't get me wrong, and I love that, but I wish we had more. Yeah. That means that also means they would be getting, good care.
Okay. Yeah. And there was another question in about the measures that you used in the Quitatex study. They wanted to know if you found any specific scales for Spanish-speaking caregivers on caregiving self-efficacy and knowledge, and if you used any translated or validated scales.
Those, let me see. For you said for which one? Sorry, competence for the preparedness for caregiving scale is the one I used.
Okay.
Yeah, I wouldn't know right now. So the CESD, the depression one, is definitely being adapted and validated to Spanish, and you will find it in the SOL study. And the great thing about this specific one is that it's validated with a population sample. So that's just an amazing, if you were to use something as validated, population sample is the best you can get. Regarding the knowledge one, is also being validated. The neuropsychiatric symptoms partly adapted definitely in the NAC, National Alzheimer's Coordinating Center. There's the severity. So yes, that part has been. I don't think it's been validated. It's been adapted. So which we don't. Basically, what it means is we don't have a Cronbach's alpha and reliability and validity measures. I mean, I did report them. I believe in this one paper, the Quitatex paper, I reported some of those psychometrics. So if anyone is interested, the ones that were not translated, we would do translation back translation following the WHO guidelines. But whenever possible, we find adapted and the best case possible validated tools. The preparedness for caregiving, I don't remember right now, but if you look at my paper, the Quitatex paper, 2022, I believe it might be, it's reported all there.
Okay. And then I think there was one more. So the same for the Quitatext intervention. Did you use the MPI for PLWD? I'm not sure of these acronyms, sorry. And
Patient living with dementia, the MPI, is that for behavioral symptoms?
I'm not sure. It's
Are we
the
at-
psychiatry inventory,
The what, sorry?
the psychiatry inventory.
Okay, yeah, so you use the NPIQ,
Okay.
and neuropsychiatric inventory
Okay.
questionnaire. So if I'm not wrong, is it 13? 10 to 13 items where basically you say if your loved one within the last month has had there's depression, anxiety, sleeping issues, hallucinations, delusions, things like that, and you will, if those that you say yes to, you say if they affect them mild, moderate, and severe. So that's the one. In the end, you get a summary score of those. We actually also had, we didn't report it here, but we also included, that's the severity part. After that, there's also a caregiver's distress one, and PIQD for distress. And that will be, once you've identified which behavioral symptoms they have, you ask them how it affects the caregiver, from nothing at all to severe. And I think there's like 5 or 6 points in that one, whereas the other one is 3.
Okay. I think if there are no other questions, we'll end here. Thank you so much for joining us. It was really great to have you. And yeah.
Thank you. It's been a pleasure.